Welcome to everyone to our webinar on COVID-19 reflections and the path to recovery.
Next speaker, I will make it shortly for the interest of the time, Dr. Greg Ciottone, who is the current president of the World Association for Disaster and Emergency Medicine and associate professor at Harvard School of Medicine. He is also an instructor in the Department of Health Policy and Management at Harvard Chen School of Public Health. In addition, Dr. Ciottone serves as a consultant to the White House medical units. He has received multiple awards, and I would like to welcome Greg now next.
Thank you all. Thank you so much, Your Excellency, for that presentation. I very much enjoyed it. Allow me to share my screen 1 minute here. So I'm going to take a look at this COVID-19 pandemic from a public health and disaster medicine perspective. And I'm going to tell a story. And the story is going to be what we've seen in the past, what we're experiencing now, and what I think the future is going to look like and how we should approach the future of this pandemic. So the first concept is to understand that the world is much like a fish tank. And in your fish tank, with all of your fish, what do you do, or what happens when one of the fish becomes ill, becomes sick? And that's an interesting concept to bring forward through this talk as we talk more about the pandemic itself. So, is there historical precedent for this? Yes and no. Certainly, 1918 was a precedent. So was 1958, 1968. But the reality is this is not 1918. We live in a different world for many different reasons. We have certainly a different healthcare system. So we really, and also we don't have any muscle memory from that. There's nobody around really from that time, even from the 50s and 60s, that's, experienced this from a professional level and understands more of what this pandemic, kind of response should be from a muscle memory point of view. But have we had experience? We certainly have. We've had a number of pandemics. Quite honestly, we have a pandemic every year with a seasonal flu, but we have a history of a number of pandemics that occurred over these last 100 years. And there's some interesting data that we can glean from these. Okay, so first off, the past two coronavirus pandemics that we've seen that have of any significance, both of them did not have a vaccine created for them. So SARS and MERS, there was never a vaccine created. And that was probably due to the fact that they sort of went away on their own. For reasons that we're not quite sure of, these viruses sort of petered out, as we say, and didn't last the amount of time and didn't have the number of ill and dead, to really prompt us to really struggle to find a vaccine. So here we are now with COVID-19. We're sitting at about 1.2 million dead globally. And the one thing that concerns, I think, a lot of us is if you look at the R0 value for these different viruses. Now, R0 is a measure of transmissibility. So the influenza viruses, the significant ones that I just mentioned, have an R0 value of about between 1.6 and 1.8. If you look at COVID-19, however, and the past coronavirus pandemics and epidemics, you see a much higher R0 value, and this is really where the concern is. If you look at it, the R0 value of COVID-19, for instance, it's nearly double what the R0 value is of influenza. Now, these are variable numbers, so nothing is exact, but that is of concern. So what that means is we need to start looking at this world, if we're going to look at it from a public health perspective, as not a world full of countries, 195, I believe it is, different countries around the world with specific borders, but from the public, or in the United States, for instance, where we have 50 states that are in a sense with COVID-19 acting like 50 different countries. Really what we need to do with public health is we need to be able to transcend these borders from the public health perspective so that we can understand this as a global issue, and we need to attack it and treat it, especially early on, as a global event. That means we need early and effective emergency management and crisis leadership, not just in a local region, a state, a country, but really around the world. And what does that exactly do? What does emergency management and crisis leadership do? Well, it takes the chaos of this disaster, and all disasters have chaos, and tries to bring it back to some form of organization and get us back on track to what we were before. That's what effective emergency management does. And essentially, we're in a race now with a very speedy, very fast virus, and very, very tricky virus. In order for us to win this race, we need to globally work as a team with that unity of mission The one mission is to beat this virus, to be faster and trickier than this virus in the way we confront it. Biological threats have been around for ages, quite literally. There are a number of different kinds of biological threats. We know about this. There are bacteria, there are viruses, there are biotoxins. There's a number of different agents out there that we have to be concerned about. We also have to understand, to get back to the fish tank analogy, that we are all living in this one world again. Okay, so it's not a matter of countries, states, borders. We essentially are all on this same planet, but we're also here with animals and in fact plants as well. And this concept of one health that you might have heard is this idea that the effects and the health conditions, viruses, other things that occur when animals actually can influence and have an effect on humans. And historically, we know in infectious disease that some of the most virulent viruses and conditions have actually made the jump from animal to animal to animal to human, and then human to human. So to be able to make those different jumps has really led to some of our most significant infectious disease crises. Looking back, and hopefully looking forward as well in the right way if a future pandemic should happen. Clearly, the steps that are most important to prevent an outbreak from becoming an epidemic or pandemic are the early steps. It's early detection, it's then containment before we even understand what it is, and then verification and the rest of the steps. So you see something that's not quite right, you contain it until you figure it out. If it's not anything different, if it's just a typical illness that you might have in your community, then fine, you don't have to necessarily take all the rest of the steps. But if it's not, if it's unique, you do. And at least you've done that early containment to try to prevent that spread. That involves different forms and different kinds of quarantines, area isolations, area containment. Some of them might be short-term until you figure out what it is. And if it's not something concerning, then fine, you can lift it. Some of it might be longer term. You might talk about weeks or maybe even months. You know, we saw Ebola escape from Central Africa to Western Africa in 2014 and 15. So it did make that jump, but then it was able to be contained in West Africa and didn't really grow to become a global pandemic. It did a lot of damage and caused a lot of deaths, unfortunately, but it was contained there. So this idea of containment and quarantine is very, very important. How do you do it? You know, and perhaps early on, especially in the case with cruise ships, we didn't quite do it the right way. You know, keeping people on a cruise ship, out to sea for the 14 days before you bring them in probably doesn't work for a droplet transmitted and aerosolized transmitted virus, right? Because we saw people getting sick. There are better ways to do these sorts of quarantines and containments, also based on transmission routes. When you do quarantine, when you do an area containment, where do you draw the line? At what point do you have to say, okay, this is where the line is going to be, and it's going to stop here with this kind of containment? The idea being that if you start getting community spread within an area, is it so important to start containing within that area, certain specific spots? I give the analogy of you're in a 2-room building, okay? If poisonous gas, let's say, is sprayed in both rooms, so it's throughout the building in both rooms, doesn't matter if you open the door or not. So this is all based on disease prevalence, and we'll get into this in a moment, but you have to understand containment and quarantine based on disease prevalence. Once you get community spread, once it's here, what do we do? Well, the end result is we have to get to vaccines and effective therapeutics, one or the other or a combination of the two. How do we do that? With non-pharmaceutical interventions. And we all know this. We've been living it for the last 9 or 10 months, right? So it's all this social distancing, personal hygiene we should be doing all the time, but social distancing, wearing of masks, lockdowns in some cases, all of these speak to community involvement. This is not a doctor curing a patient, okay? This is a community curing itself. This is public health, the best that you can do for the greater good. So eradication is pretty simple, right? I mean, if I were in a utopian world, let's say, able to take every human being, put them in a box, and let them not communicate with any other human being for the next 2 weeks, COVID-19 would almost disappear, right? But of course, we can't do that. So all of these social distancing steps, all these non-pharmaceutical interventions are steps we're taking to try to approximate that idea of isolating so we don't let the virus transmit between each other. And what's the end game? The end game of vaccines and therapeutics. Yes, we can argue about, what's the efficacy of a vaccine? How much immunity does it give? Some cases it gives really good immunity, some cases not so much. But it's some combination of this that's going to get us over that hump to the other side of this pandemic. So while COVID-19 will probably still be here forever, or at least the foreseeable future, and we will probably have our annual COVID vaccine as well as our annual flu vaccine, this is what we're trying to bridge to with the non-pharmaceutical interventions, the community healing itself. So, and then we get past that, we get on the other side of this pandemic. What's the future? What do we have to do? Prevention. It's public education, personal hygiene, always. Mitigation. Okay, when it comes, you detect it, contain it. And once you contain it, if it doesn't work, if you're starting to get community spread, then all these social distancing strategies and masks, right? And then finally, preparedness. We need to prepare for this. We need to do a little bit better job preparing for this. We should have predicted as a global community, we should have predicted based on Ebola and some other things that we probably need a little bit more PPE. And maybe we can solve that problem in the future with supply chain and some other things. What did Ebola teach us about PPE? Well, not only do we need a lot of it, we need to have effective PPE, and we need to choose the right PPE strategies for the kind of virus we're dealing with. Ebola is transmitted through, it's a liquid, lots of liquids in Ebola patients, contact in that sense, whereas a respiratory virus is different. It's the droplet, it's the aerosolized. Choose our PPE according to what we're dealing with. All right, so now let's look forward. Path to recovery, it's stopping the spread. There's nothing magical here, okay? The virus cannot walk down the street, knock on your door, and infect you. It's got to be spread between people. So the whole overarching concept of stopping the spread is making it so that the virus can't jump from one person to the other. What does that mean? First, we have to understand it. Droplet versus aerosolized. Does it matter? Yeah, it does a little bit. Droplet transmission are essentially viral units in droplets of liquid that can be spread. And we see, the demonstrations, maybe, feet, 10, 15 feet, perhaps on a vigorous a sneeze. But that's essentially what droplet spread is. Aerosolized means that the virus itself can be floating in the air. Now, perhaps it's in these micro droplets as well, but it can disperse over much higher and much greater area. So the two combined, it's not even two separate things. It's almost like a continuum. Viruses in big droplets that are sprayed, that way, almost directly to you or on surfaces, and then the aerosolized version of that, which is sort of micro droplets and or just the virus itself kind of floating over a larger area. So why is that important? It's important because we have to understand that bioagents, very small numbers of bioagents in some cases can actually cause illness and cause disease, okay? So if you look at some of these numbers, you realize that just on a surface, on a head of a pin or what have you, there could be potentially enough viral units that could make me sick. And this is why we get into this idea of deep cleaning and keeping our surfaces clean, using the disinfectant, solutions in our hands, doing all these things to try to get the virus off of surfaces. Now, you might have heard about fogging, disinfecting, and then electrostatic cleaning. Similar things, but different in this sense. A fogger, which is a variation of what you're seeing in the picture, will spread the disinfectant over, and everywhere it lands over an area, and everywhere it lands, that's where it sits and disinfects. An electrostatic sprayer will take that same disinfectant, but as it jets out the end, it will put a positive charge on the particles. That does two things. One, it makes the particles repel each other, so it goes, spreads out over a bigger area. And two, because most surfaces are negatively charged, it actually goes into nooks and crannies and areas where you might not just normally get with a fogger. So it's actually a deeper cleaning kind of a disinfectant. These are different ideas. Make sure if you do these things and when you do these things, you use EPA-approved disinfectants. Testing. If we don't do adequate testing, and you've heard a lot of things in the news and the press and other things about testing, different sides of the argument. The reality is if we don't have adequate testing and we don't do adequate testing, then our enemy is truly invisible. And it's hard to fight an invisible enemy. The more we know where the enemy is, where this virus is and who has it, the better we can do things like contact tracing, isolation, containment, et cetera. So we also have to understand that as of now, though things are getting better, certainly earlier, we didn't have enough testing capacity. So what are some of the ways that we can maybe help to alleviate that or make better use of the testing capacity that we have? One of them is pooled testing. This idea of pooled testing is you take, let's say 20 people, you sample all 20 people, but you test only one. If that test is negative, you make the assumption those 20 are negative and off you go. If the test is positive, then you have to test all 20 people. Now, this is not rocket science, right? So this obviously is based on disease prevalence, mainly, because if you have disease prevalence that's relatively low in your community, 1% less, 2%, 3%, then this kind of thing will work. It will save testing capacity and be relatively accurate. If you get disease prevalence, however, that's up higher, 10%, 15%, this doesn't work, because then you end up, having so many positive tests that you'll end up testing everybody anyway. So there's limitations to pool testing, but it is a way in low disease prevalence to perhaps, increase your testing capacity. What's another unique thing to do? Wastewater surveillance. We are learning more and more about this and implementing this more and more, and it's a really good tool. Doesn't sound really pleasant, but it's a really good tool. It's actually being used by a number of universities now. We have seen now that you can actually detect the viral, the RNA, the viral particles in wastewater, literally hours to a couple days or more before people become symptomatic. This is now being used in some universities around the country. There's actually wastewater being tested daily from dorms that when it becomes negative, you go and you test and you find somebody who's actually positive, probably and most likely before they're even symptomatic. You remove that person and it's remarkable how quickly that goes away in the wastewater. So it's a very sensitive and specific actually test, and it's a great thing to do, and we're using it more and more. So this idea is we're trying to move forward with all these NPIs to flatten that curve, because as we know, this came from 1918, the Philadelphia and St. Louis experiments, as you know, locking down 1 or 2 days once you get the first tests cases versus 2 or 3 weeks after you get the first cases. You have the first curve that overcame healthcare capacity, then you have the second curve that stayed below. This is what we're trying to do. It's what we're trying to do in the beginning of the pandemic. It's what we're trying to do now. And if the second surge comes, which it certainly looks like it's coming, it's what we're going to try to do. And that is all about NPIs and social distancing. It's all about these things. Some of them are draconian. A lot of them are unpleasant. We don't like being locked down. We certainly don't like having to not being able to go to work or this or that. But there are some steps that we have to take to make sure that we separate ourselves so that virus can't be transmitted, or at least we limit the transmission as much as we can. So these social distancing strategies have to occur again in the second stage. Unfortunately, they have to be triggered early, and they have to use and compliance, is really very, very important. But they have to be based on science, on data. Look at things like disease prevalence. Make decisions based on that. This is why you're seeing, in the United States, each state seems to be every day changing, certain parameters. Like yesterday, we could have people from New Jersey come to Massachusetts. Today, we can't unless they have a negative test or they quarantine. These are all changing based on our best impressions on trying to interpret the disease prevalence and where we are with this virus. Now, I want to put one controversy to rest. This idea that social distancing strategies are not good because they don't allow herd immunity to build. That's not right. I don't think anybody would argue that's the right way to go, because then if you do that, you're subjecting yourself to the case fatality rate of that where you are, that region or country where you are. And that's just not the right way to do it. We can achieve herd immunity. We should do that, but we should do it through vaccines. And then again, also whoever's recovered, but of course we don't want to, make it so that we want to decrease the transmission rate. Because if you look at the case fatality rate, let's say it hovers around 1%. It's a little bit lower in some places, a little bit higher in other places. Let's say it's hovering around 1% case fatality rate. That means in the United States, and if you have to reach 60 to 80% herd immunity, that means in the United States, you would be subjecting between 1.5 and 2 million people essentially to death. That would be the number of people that would die if you had to achieve the 60 to 80% herd immunity by just letting people get exposed. I don't think anybody would think that's acceptable. We have to think about other things as well. The K factor. It's not just the R naught, the transmission, but it's the K factor. So it's not just that you're gathering, it's what you're doing while you're gathering and where. We do know that outside is about 20 times less likely to transmit the virus than indoors. We know that. But also it's what you're doing. Are you singing in this case? Are you yelling? Are you exerting yourself and breathing heavily? And we found that will actually transmit the virus as well much more effectively. The lower the K value, the more of that sort of transmission because of the dispersion effect happens. COVID's pretty low. It's 0.1. It's even lower than MERS and SARS. And we've seen clusters caused by this. We saw clusters early on in Washington State with a Zumba class, and we've seen some other things. I don't even know what Zumba is, but it's something that where you exert yourself a lot, I guess. So we need to look at the R naught value, the K factor. We need to put all this together, but none of these things are going to be effective if we don't have good testing and contact tracing. That's going to be very, very important. When we look at things like reopening, which we've been doing, and then if we have to close again, how do we do that? And then how do we start to reopen again? This has implications for workplace, mass transit, any kind of gatherings, and of course the economy. So down-regulation of SDS, social distancing strategies, should mirror the triggering. So the way we kind of trigger them is the way we should downgrade them. And we should understand there's going to be hills and valleys with this, okay? It's just the nature of the beast, and we have to be able to go with that. Now, there's a few complicating issues, though, when you look at triggering and then downregulating. The graph on the left are countries early on in this pandemic, deaths per million that reached, and it kept on going up. The graph on the right is later in the pandemic. I think it's around August-ish to September. And that's where you see a lot of countries that have plateaued. Death rate wasn't going up, and that's great. Now they're starting to go up, second surge. But you see a handful of countries that it never plateaued. United States is one of them, where it's just still going up. This is a complicating factor. And the other issue is, and you know, I love Mr. Friedman's talk, you know, because it seems like he was saying everything I'm trying to say with this, and I'm just maybe trying to give a little bit of public health and science to his argument. His argument was spot on. We can't do this in isolation in healthcare, okay? We have the economy to worry about. And that's why with this idea of crisis leadership, we always say that outside of the silos is the way this has to happen. We need to talk to each other. When we report up to policymakers, the scientists need to report up, the economists need to report up, the doctors caring for patients need to report up. All of this information from subject matter experts has to be assimilated and then projected out in policy so that we do the most good for the most people, and we treat the healthcare crisis, which is obviously important, but also the economic crisis, which is almost equally important. Because if we don't have any economies, if they're all decimated at the end of this pandemic, where are we? We're not going to be able to have good health care, among other things. So the economy is the gorilla in the room, and we have to balance this. It's all about balancing our NPIs with the economic recovery and making sure that as we downregulate social distancing strategies, we keep that in mind, okay? And always keep the end goal in mind. It's the vaccines and therapeutics. We will get one. I'm convinced we'll get a vaccine. There's just been too much effort into it, too many promising vaccines on the near horizon. We will get it. So we have to get it, and then we have to distribute it, and we have to keep on doing all this stuff and get on the other side of this pandemic. And I can say probably the most important part of NPIs is the mask wearing. Cannot impress on that enough on people. You saw His Excellency talk a little bit about schools and infection rates in children and adolescents. It's important as we start opening up schools and universities. What we're seeing is that, yes, kids have a lower case fatality rate, but they still transmit it, right? And they can transmit it actually out into the community. So some of the graphs, like the one on the right, that we see of universities, not only are seeing a spike in cases in universities, we're actually seeing it in the communities where universities are. So there is that idea that kids may not die of it of the same case fatality rate, but they certainly can transmit it, and we have to keep that in account when we do this. So what are the economic implications of this? The biggest thing is gatherings, and I'm not just talking about mass gatherings. Pretty much everything we do as work, as part of the economy, is gatherings, right? We gather in the office place, we gather in a restaurant, we gather in all these other economic areas. So we need to look very hard about gatherings and how we reopen gatherings in the right way, smaller gatherings to bigger gatherings. And this is why it's been so important, and there's been so much issues in looking at businesses and how businesses, try to reopen. Understand also that there will be and continue to be transportation risks. As long as you have different disease prevalence rates around the world, there will be transportation issues. Because the reality is, yes, you don't want to take a place, let's say like a Caribbean island, where they've done very well, or some other countries that have done really well and have a very low disease prevalence rate. You don't want to then have a lot of transportation coming in from a place with high transmission rates and high disease prevalence. This is important. So yes, there'll be some transportation issues and probably some blocking of transportation for the short term and the months to come. Also understand there are other diseases out there. Diseases and injuries and the rest of healthcare hasn't gone away. They're still there. So how do we do some of these things? In my world of disaster medicine, one of the things we're really looking very hard at is natural disasters, hurricanes, other things. We use, strategies like sheltering very much in these sort of responses. What does sheltering look like in the COVID-19 era, right? Very difficult things to deal with. So there's unique issues in pandemic response to any biologic agent, but certainly here as well. And probably the most important one is this idea of there are recovery arcs of time. This is not a linear event. It's not like a bomb went off, right? An explosion, bomb went off, We go, we respond to it, it's done, it's over. These have many different arcs of time. We just identified it and tried to contain it. It's now got community spread. Okay, now we've locked down. Okay, now we're reopening. All these different arcs of times that are overlapping and happening. And we can't always predict them. Modeling is good, but modeling is only based on the information you have. If you don't have strict data, your modeling is not maybe going to be 100% accurate. But we do our best. So we have to look at all these different implications. So to kind of wrap this up a little bit, the key reopening elements of this are disease prevalence. We have to understand that, okay? Social distancing, non-pharmaceutical interventions until we get that vaccine or really effective therapeutic or both. That's very important. Testing, I can't say how important testing is. Again, to understand where that invisible enemy is. New strategies for disease prevalence and surveillance. Wastewater surveillance looks pretty good, okay? We need strong leadership and emergency management. We need to be able to have people assimilate all this and make good data-driven policies. We need to get ourselves to the vaccines and therapeutics, but then we need to learn the lessons. We've had all these pandemics historically. We still have missed some lessons. We still let some of these things escape and containment and other things that we got to get better. So in the future, we need global participation. It's not 195 countries, it's one world that we're living in. Early containment is crucial, I've said it 100 times. Borders are porous, diseases don't care about borders for the most part. Our travel allows us to get diseases from one part of the world to the other in about 12 or 18 hours. That's concerning. And remember the nightmare scenario. And what is that? Well, I'm sitting here now to say that if we don't get some of these lessons right, and we've had plenty of opportunity with past pandemics, but if we don't get some of these lessons right, we're going to be subjected to something that would make anybody lose sleep, okay? Certainly all of us in the healthcare world. And that's the nightmare scenario. What if a novel virus emerges with the R0 value, the transmissibility of measles or mumps, which is many times, 10 times or more transmissible than COVID, has a low K factor, right? The dispersion factor, kind of like COVID, but has a case fatality rate of Ebola, 50 to 70%, or rabies, approximating 100%. Not only would that decimate our healthcare systems, our economies, but I argue that would threaten us as a species. And this is the concern. But there is light at the end of the tunnel. We can learn some of these things. We can learn about early detection and containment. We can really do a good job with these non-pharmaceutical interventions. We can understand our NOT and KVAC values and take them into account when we do this. We can trigger crisis standards of care when we need them. We haven't talked a lot about this, but crisis standards of care are the idea of, again, providing the most good for the most people, public health. So this is going forward. We're trying to bridge ourselves with vaccines and therapeutics. I think there's a path forward. I think that we need to work together as a global society, a global community to do that. So thank you very much. If there's time, I'll take a few questions. Otherwise, I appreciate you having me speak at this important conference.
Thank you, Greg. So any question, like you have a few minutes for questions.
Yeah, I'll try to combine a couple of questions with a similar theme, which is how can we continue caring for patients in the hospital setting while we need to manage distancing and help both patients and our healthcare colleagues remain safe? So for example, in the outpatient clinics, be able to take care of patients with other diseases and decrease crowds at the same time. We also have operating rooms and emergency departments, and especially in the setting of patients with these symptoms who are also anxious, how can we manage this?
Yeah, well, some of the management you're going to hear very soon with some, we have some great speakers coming up. But, as an overarching kind of short answer, it's PPE. We have to understand PPE and understand when to wear, where to, in what situations to wear it. Do I wear a PAPR when I'm intubating somebody who is an N95 and a face shield adequate? These are some of the things we have to sort out and understand. But, it reminds me back of the HIV days. And I grew up in medicine. I trained during the HIV pandemic, essentially, when it was in the days where we just couldn't treat it. It was essentially a death sentence. And I remember vividly being an emergency medicine resident, in the trauma room, being covered in blood more often than not, and flying around on a helicopter doing things like that, at trauma scenes, being scared, that if I get a needle prick, a little blood, it's going to be a death sentence. And that's really where universal precautions came to be, this idea of universal precautions. And what we did back then, because the estimate was 30% or so of everybody who presented the emergency department was HIV positive back in the day, is we assumed everybody had it. Now, that's kind of a variation of what we're talking about here, but essentially, we need to try to be data-driven in the PPE that we use and in what circumstance we use it. But if ever is a case that we're not able to be fully data-driven in that, we need to err on the side of being conservative. So it's that kind of universal precautions thing. So don't go lower on your PPE, go higher if you're not quite sure.